Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Hello everyone, my name is Asthik. I'm a consultant radiologist at Great Ormond Street Hospital. In this lecture, I'll provide you with some top tips for pediatric hearing loss. Before I begin, I'd like to acknowledge Dr. Shivaprakash from Toronto and my colleagues at Great Ormond Street Hospital for providing me with some of these slides. Here are a list of papers and review articles that I have found useful in preparing this lecture. So top tip number one, when evaluating conductive hearing loss, a CT should be done. And this should be the standard of practice is a high resolution CT of the temporal bone, but increasingly other techniques such as cone beam CT is being performed. Contrast should be given if we are suspecting coalescent mastocytitis or other infections, vascular lesions or tumors. So cone beam, just a couple of words about cone beam CT. It has a higher spatial resolution than the HRCT and also offers the advantage of lower radiation dose. But it is also susceptible to beam hardening artifacts and also requires a longer scanning time. Also the patients will need to be in a sitting position and along with the longer scanning time, these may predispose them to move, and motion artifacts may deteriorate the image quality. So there are some advantages and disadvantages. A number of newer techniques have now been described. For example, the ultra high resolution CT and the photon counting CT. So the ultra high resolution CT, you can see the images are exceptionally sharp with less noise, and there's very high resolution detail of the finer anatomical structures. For example, we can see the head of the malleus and body of incus, good detail of the stapes, the greater superficial petrosal nerve, anterior ligament of malleus and the pyramidal eminence, and so on. Similarly, photon counting CT, there's very good detail of the cochlear structures and the modulus. The other advantage of photon counting CT being that it does it with a lower radiation dose. The main limitations of these newer techniques are, of course, the cost and availability of these scanners and also the need for specialized knowledge and training for optimal use. Tip number two, abnormalities in conductive hearing loss can be located anywhere from the pinna to the footplate of the stapes, as well as third window lesions. So when you're reading a report of suspected, when you're reading a study of suspected conductive hearing loss, ensure that you review all of these areas. Basically anything that blocks the passage of sound across these structures can result in conductive hearing loss. So it can be something as benign as some earwax or a fusion in the middle ear cavity, but it can also be something more sophisticated such as stenosis or atresia of the external auditory canal. As we can see in this case, in this particular case, there is an osseous plate. The level of the oval window and the facial nerve canal is inferiorly displaced, in keeping with oval window atresia, and in this case there is dehiscence of the superior semicircular canal, which prompts abnormal communication between the inner ear structures and the cranial cavity. Third window lesions can also have abnormal communication between the inner ear structures and middle ear cavity. Essentially what happens in the presence of third window lesions is that acoustic energy that is inputted at the oval window is shunted, and this results in reduced perception of the air conducted sounds. It is a form of pseudoconductive hearing loss. Top tip number three, external ear anomalies are commonly associated with anomalies of the middle ear cavities. So in this case, we note there is external auditory canal atresia, but The miliar ossicles are also small in size and dysplastic. So these are known as congenital external and miliar malformations. The congenital external and miliar malformations can be non-syndromic and syndromic. The non-syndromic ones are usually unilateral. So the clues to look for are anoxia, microtia, an abnormal shape of the pinna, and stenosis and atresia of the external auditory canals. These should prompt you to also look at the miliar cavities, and there was abnormal and dysplastic ossicular structures in this case. The syndromic ones tend to be more commonly bilateral, but they can also be unilateral, and they are usually associated with other craniofacial features, other systemic manifestations, including other organ involvement. Locally, they can have skin tags, fistulae, and cysts, as well as sinuses. In this particular case, there is a cyst, and the ossicular structures were dysplastic with some fusion, and this was the case of branchio-otorenal syndrome. How do you differentiate between external auditory canal atresia and stenosis? So a useful clue is to look for the presence of the tympanic plate and tympanic membrane. So in these two different cases, the right side is normal with a normal tympanic plate and membrane. In case number one, the left side is abnormal, and you notice that there is no tympanic plate. So this is a case of EAC atresia. Case number two, there is a tympanic plate, and we can see that quite nicely here, but the canal is stenosed. So this is quite a useful feature to look at to differentiate between these two entities. Another useful tip is that ossicular erosion is not specific for cholesteatoma. And I wanted to stress on this because this is quite a common scenario where we're asked to provide a report on a query cholesteatoma, and the clinicians ask us, could this be cholesteatoma or not? And we quite frequently see some non-specific soft tissue opacification in the miliar cavities along with ossicular erosion. So the importance here is to describe these findings as such, but to confirm whether there is indeed a cholesteatoma or not, we need to do a diffusion sequence, particularly a non-EPI diffusion. Cholesteatoma would typically show restricted diffusion, whereas post-inflammatory etiologies of ossicular erosion, also known as non-cholesteatomatous ossicular erosion, would be diffusion negative. The next top tip is again to reinforce that non-EPI diffusion weighted sequence should be done for cholesteatoma. The reason being that there's a lot of artifacts at the bone air interface with the regular diffusion weighted sequence that we see here. But with a non-EPI protocol, these artifacts are not there, and we can clearly identify the diffusion hyperintense material within the miliar cavity in keeping with cholesteatoma. We now move on to more complicated cases of syndromic hearing loss. So top tip number 7, syndromic hearing loss can be conductive, sensorineural, or mixed. And this is because anomalies can occur anywhere between the external, middle, and inner ear structures. So in this case, we'll start off with the inner ear. There is cochlear hypoplasia. The vestibule is dysplastic and the semicircular canals are absent. On the sagittal reconstructed images of the IAC, we can see instead of the normal 4 dots, we only see 1 dot, and the cochlear nerve is absent. Similarly, on the left side, we don't see anything except for perhaps a thin dot here. So there's cochlear hypoplasia, and the cochlear nerves are not visualized, in addition to there being absent semicircular canals. So these features should already point us to a certain syndromic etiology, and we'll see the answer to that soon. Also, the other review areas for this particular syndrome are the olfactory bulbs, which are absent. A sagittal T1 midline image is very useful to look at the midline structures, such as the corpus callosum, which is thin, and the pons, which is hypoplastic. And if you notice closely, there is a clefting of the clivus at this level. So all of these features put together are typical for CHARGE syndrome due to CHD7 mutations. This is another example of a syndromic hearing loss. On this image, contrast-enhanced axial CT, we see a cystic lesion that is closely related to the right external auditory canal, and this was type 1 branchial cleft cyst. On this image, the cochlea is hypoplastic. We can see that there is an anteromedial offset of the hypoplastic apical and middle turns away from this tapered basal turn, which has been described as an unwound cochlea. And on this MR image, we notice that the internal auditory canal is enlarged and has a bulbous appearance. So these findings put together are quite typical for bronchio-otorhinal syndrome, in this particular case due to an ER1 mutation. So ER1 is the most common mutation underlying this syndrome. It has a role in embryogenesis of the ear branchial arches, the ocular structures, and the kidney, and therefore mutations in this can affect all of these structures to varying degrees. So when we see a branchial apparatus anomaly along with an unwound cochlea, it is quite characteristic of bronchio-otorhinal syndrome. Other mutations have also been described, like 6.1 and 6.5. So when these findings are present, we can suggest panel testing for these genes. Coming to top tip number 8. Inner ear malformations comprise a spectrum of abnormalities. For example, the cochlear nerve can be aplastic or hypoplastic. I've put aplasia in inverted commas here because even though we are unable to see it on MRI, does not mean it is fully absent. That is, there may be a thin strand of tissue that is not resolved by some imaging. But important to look for these structures on the sagittal oblique images, that is the 4 dots. In this case, we can see that the nerve is present, but it is small in size. Similarly, the labyrinthine structures show a spectrum, the most severe end being labyrinthine aplasia, where there is no discernible cochlea or vestibule. In this case of cochlear aplasia, we see only a rudimentary vestibule, that's the internal auditory meatus, and there is no cochlea. In this particular case, a cochlea is present, but it is hypoplastic, particularly involving the middle and apical turns. And then we see the spectrum of common cavity IP1, IP2, and IP3, where there is variable differentiation of the cochlea and vestibule, from the least differentiated being common cavity to more differentiated forms. So while classification of these into these discrete entities is useful, it certainly helps us. It is also important to note that in routine practice, we commonly encounter cases that do not fall within the strict confines of any of this, and therefore all of these should be looked at as a spectrum. There are, however, certain imaging phenotypes which have consistent features and are strongly linked to particular genes, that is, with excellent genotype-phenotype correlations. One such example is Pendret syndrome caused by SLC26A mutations on chromosome 7. Pendret syndrome should be raised when encountered with bilateral IP2 malformations with vestibular aqueduct dilatation. It is the most common cause of syndromic congenital hearing loss. The gene product of SLC26A is pendrin, which is expressed in the inner ear and thyroid gland. Patients with Pendret syndrome therefore also have quite often thyroid abnormalities manifested as goiter. Another good example of strong genotype-phenotype correlation is X-linked deafness caused by POU3F4 mutations. This is characterized by congenital mixed hearing loss, which is profound and progressive. The sensory neural hearing loss component is due to the symmetric cochlear malformation, and the conductive component is attributed to a fixed stapes or third window phenomenon. The imaging features are typical with bilateral incomplete partition type 3, which on imaging demonstrates a corkscrew or a Christmas tree appearance. There is also enlargement, bulbous enlargement of the internal auditory canals, which leads to abnormal communication between the subarachnoid space and the perilymph. And this increases the CSF, the risk of CSF leak and gusher during surgery. Another malformation that has been recently described in patients with X-linked deafness is hypothalamic malformations, and these can range from just a lumpy, bumpy appearance to what we see here to a frank hamartoma. This has been postulated to a role that POU gene family plays in hypothalamic development. We will now discuss a few important tips for the preoperative evaluation of cochlear implantation. A few points about surgical approach. A cortical mastoidectomy is performed followed by posterior tympanotomy to access the middle cavity. The cochlear opening is performed usually via the oval window, and this is preferred over a cochleostomy to prevent damage to the hair cells and the osteospiral lamina. So it is useful to have an imaging checklist prior to cochlear implantation. Possibly the most important questions we need to answer are: is the cochlear nerve present? Is there cochlear aperture stenosis? And are there any inner ear malformations? So the cochlear aperture is best assessed on an axial CT at this level, and we can see that is the cochlear aperture. It has a normal width of approximately 2.1 plus or minus 0.5 millimeters. The cochlear nerves per se are best imaged on heavily T2 weighted cis or drive sequences with sagittal oblique reformats as seen here. So we should be seeing the normal 4 dots within the internal auditory canal. So that's starting from the facial nerve and going clockwise, the superior vestibular and inferior vestibular nerves, and finally the cochlear nerve, which is located in the antero-inferior aspect of the internal auditory canal. In this particular case, we can see there is a facial nerve, a superior and an inferior vestibular nerve, but the cochlear nerve is not present. So this should be reported as non-visualization of the cochlear nerve, and we'll come to the importance of that in the next slide. So generally, cochlear implantation can be offered in conditions where there is an intact cochlear nerve, and also in the presence of inner ear malformations such as common cavity malformations, cochlear hypoplasia, incomplete partition type malformations, and cochlear nerve hypoplasia. Cochlear implantation is contraindicated whenever there are malformations that involve absence of the cochlea, such as labyrinthine aplasia, cochlear aplasia, and in those malformations where there is a lack of communication with the brainstem, such as a rudimentary otocyst. So for these conditions, auditory brainstem implantation may be indicated for hearing rehabilitation. Coming back to the absent cochlear nerve on imaging, this is a cautionary note. So this was previously thought to be an absolute contraindication, but now is more appropriately considered to be a relative contraindication. So studies have shown that children with apparently absent cochlear nerves can still benefit from cochlear implantation. The reasons for this are twofold. One is remnants of cochlear nerve may be too small for us to resolve with current MRI techniques. And secondly, there may be some viable cochlear nerve fibers incorporated into the facial nerve. And therefore, when we see this appearance, rather than labeling it very dogmatically as cochlear aplasia, we should just say that the cochlear nerve is not clearly identified on imaging, and then based on MDT discussions and other tests, the patient may still be offered a cochlear implantation. Another important consideration is the degree of mastoid pneumatization, which can be classified as hyponeumatized, normal pneumatization, and hyperpneumatization. The problem arises if it is hyponeumatized, and we'll see why that is. The other important factor to consider is the tegmen height, which is best appreciated on a coronal reformat. A low-lying tegmen is defined as one of a height less than 3.5 millimeters. Why are these important? So a hyponeumatized mastoid is usually associated also with a low-lying or a poor height of the tegmen and a low-lying dura. And these are generally associated with difficult cortical mastoidectomies, as well as increased risk for dural exposure, because the space between between the axis and the dura is very less, and therefore they're also at increased risk for meningoencephalocele, CSF leaks, and meningitis. Other important considerations are, is there any middle ear disease in the form of mastoiditis, tympanosclerosis, or cholesteatoma, because these will need to be treated prior to cochlear implantation. We should also look for arterial and venous anatomical variants, such as an aberrant ICA, which is seen in this case because these aberrant vessels that goes through the surgical corridor are prone to iatrogenic injury. We should also look for the presence of a persistent stapedial artery, because this can overlie the cochlear promontory and cause very intimately or parallel to the facial nerve canal, and is also at risk for injury from surgery. A useful clue is looking for the presence or absence of the foramen spinosum. That's the foramen ovale. The foramen spinosum is normally posterolateral to the foramen ovale. So absence of the foramen spinosum indicates a persistent stapedial artery. Other vascular variants that must be reported on are the presence of high-riding jugular bulbs, the His and jugular bulb, and the presence of mastoid emissary veins, as these vascular variants are also at increased risk from iatrogenic injury. With this, I conclude this lecture. I thank you very much for your attention.